First of all, I would like to thank Dr. Iaconou for the very kind invitation to participate in this session. So I'm going to, in the next few minutes, to present a case about a complicated redo mitral valve paravalvular leak closure. So our patient is a 68-year-old woman who, despite her low age, had a very complicated past medical history. She had undergone the past 3 times surgery of the mitral valve with back in 1997, 1998, and the last time in 2014. And since then, she had the Sorin 25 millimeters valve. She also suffers from chronic kidney disease, stage 4. She has right ventricular heart failure, and since 2008, she has a permanent pacemaker implanted, and she also suffers from permanent atrial fibrillations. She came to us due to symptoms of fatigue, new onset dyspnea with characters of orthopnea, with a very severely reduced exercise capacity, New York Heart Association class 3. From the labs, she had some signs of mild hemolysis and high BNP. As expected, initially we proceed with a transthoracic echo showing good LV function and a paravalvular leak in the mitral valve position. She had right high RV pressures and pulmonary vein systolic flow reverse. As you can see on the right side, we proceed with a TOE in order to investigate further the location of the paravalvular leak. And as you can see, it was you can see at hour 6 in the posterior wall with measures of 5 by 8 millimeters. So based on that and the very high surgical risk, we decided to proceed with the transcatheter PVL closure. Here you can see the attempt to cross to do the transeptal puncture. Due to very thick and fibrotic septum, we had to use the Bailey's radiofrequency needle. As you can see on the left side, it was quite easy using this device to cross the septum. However, we were not able to further cross the catheters, and we had to dilate further the septum with 8 by 40 millimeters balloon. So the next step was to advance 12 French flex cath, which is a steerable catheter in LA. And using that, we can manipulate and we can position the catheter just above the leak. And using the mother and child technique with a long MPA 5 French catheter in a guide 6 French catheter MPA again, we managed to cross the leak with hydrophilic Terumo wire. Following that, we advanced a super stiff wire in LV. And finally, we implanted successfully an Amplatzer vascular plug 3 device, 14 by 5 millimeters. As you can see here, the device is successfully released. And on the right side, you can see upright the initial picture of the valve. You can see the PVL, and just below, you can see the device here, and the successful closure of the leak. However, 7 months later, the patient came back. She presented with recurrent signs of dyspnea, and as expected, we conducted a new TOE, which revealed a new PVL just close next to the previous implanted device. You can see on the up right side, and you can see the new leak just next to the first initial implanted device. So the surgical risk remains high, so we decided to continue further with a new attempt for a PVL closure. Again, we use the Bailey's radiofrequency needle in order to cross the septum. And with the flex cath steerable catheter, we managed to cross the leak with a hydrophilic wire. However, if you see here, during the manipulations in order to advance the catheters, the initial implant device embolized in the left atrium like a fly, and there was an increased risk to get stuck and trapped in the mitral valve. So we decided to proceed with trying to catch the device and pull it back in the flex catheter. The only device we had available in the cath lab was a only single loop snare system that we used, as you can see here, and we managed to retrieve the device, catch the device, and retrieve it back in the tip of the 12 French catheter. However, we were not able to retrieve the whole device in the catheter, but it was partially retrieved, and that was quite tricky. So the next step was to pull it back in the right atrium, partially collapsed in the sheath, and we think that it was possible to pull it back in the right atrium due to the stiff fibrotic atrial septum, due to the repeated surgeries. So we managed to retrieve the whole system back in the right atrium, and the plan was to bring it back in the femoral vein. However, as you can see here, we conducted an angiography from a contralateral vein because, as you can see, the device was quite, due to the large dimensions, we were not able to take it back through the vein. So we called the vascular surgeons, and they helped us in order to retrieve the whole system successfully. Here's the embolized device outside. As you can see, if we had an alligator clip, which could be more useful in order to catch the device from its pins, and it would be able to elongate the whole device. On the other hand, with the loop, which actually we grab the device from the waist between the two discs. You cannot elongate the device, and it's not easy to take it back in the sheath. So it would be useful to have more devices in the cath lab. The patient remained initially hemodynamic stable, extubated. However, a few hours later, she required inotropes. The decision was made to send for a surgery. She had a very long post-surgical course, and unfortunately, she passed away 3 weeks after surgery due to multi-organ failure. So a lot of complications can happen after a PVL closure. Device embolization, as we saw here, valve interference, as you can see in another case of our lab. Here is the device actually interfering with one disc of the mitral valve, and you have to remove and change the orientation in order to avoid interference. It can happen pericardial effusion, heart block, coronary ostial occlusion. A lot of things can go wrong. So closing. Comparing surgery and transcatheter treatment for PVL management, we don't have any randomized trials. However, we have data from registries and meta-analysis like this one, which showed that there's no difference in all-cause mortality between the two modalities. Also, another meta-analysis of 22 studies showed that surgical repair is associated with higher rate of technical success, but with worse short-term outcomes. So, surgical repair should be chosen when you have active endocarditis, when you have a very unstable valve, or when there is need for concomitant cardiac surgery. And also there are data showing that patients with technical failure in a percutaneous approach did not have increased mortality after surgical repair compared with those who underwent surgical repair upfront. So this suggests that there are complementary methods, and both surgery and transcatheter closure. So closing, in conclusion, the transcatheter closure offers, of course, is less invasive. It offers better in-hospital short-term outcomes compared to surgery. However, the long-term follow-up, the two methods have comparable outcomes. PVL is a common and underdiagnosed complications of both surgical and transcatheter valve replacement. Percutaneous closure is feasible, but with a significant learning curve. Imaging is the key to success for both pre-procedural planning and procedural guidance, and requires, of course, a very good collaboration between the interventional team and the imaging cardiologist. Thank you.
So thank you, Dr. Kalogeras. This is an amazing case. very learnful, depicts the difficulty in placing another device adjacent to the previously placed. So you know, we have to be very careful, especially if it's a lateral one, more
it was,
lateral.
posterior medial.
Posterior medial.
Yes.
Yeah, because I thought it was lateral. So yes. What would you think would you do different from the first time? You know, in the second time, you place the same the same plug, or it's?
I'm not sure it's a problem of the plug.
Yeah.
Actually, this lady was very, very, very fragile, very fragile lady. 3 surgeries in the past. So I think again we will go with the same plan, transcatheter closure. Again, the second procedure, because of the position of the leak, somebody could think about transapical access,
yes,
which could be less dangerous for embolizing the device. On the other hand, she's a very fragile patient, and what you want to avoid is to be very
yes, to be very, very meticulous in closing.
So
yes,
I'm not sure we would go with something different.
Yeah.
What the learning from this case was to have more equipment in the cath lab, and we have now in this alligator clip, just in case if we need it in the future.
Yeah, this is very important. Dr. Leontiadis.
Congratulations on the presentation. Did you answer the question why this happened in the first place? I mean, was this kind of a rocking valve, or was it the dehiscence? If you put the second plug, did you ever think that maybe you could have a leak on another position of that? You know what I mean? Did you have any clue that maybe this was a dehiscence of the surgical valve? I mean, this was a fragile.
There were no signs of endocarditis, if you mean.
No. I mean, because it was a frail patient, so maybe if you put the second plug in, maybe 3 months later, she would come with another hole in the ring. I mean, this is something that you think about the pathology.
Yes, it's something that we see quite often. I mean, you put a plug and then a new leak happens. It's something quite often in my experience. So, and sometimes even if you leave behind a small leak, the hemolysis problem doesn't resolve always. Patients still remain with hemolysis problem.
Notice, Dr. Mezilis?
One thing that you might consider doing differently from the first procedure is trying to deploy 2 plugs simultaneously. This large hole sometimes requires 2 plugs, and the only way you can do that is by deploying them simultaneously. Otherwise, the one may sort of push the other one, and then you the results to the condition that you had here. That's probably the only thing that you might.
Yeah, but if you see the result in the echo, the first procedure, it was quite good, and it was not the hemolysis problem of this patient; it was the heart failure problem. So you want to reduce the residual the regurgitation as much as you can. So the initial procedure result was quite good. However, I think there was a progress of the disease. I don't know what. So it deteriorated.
Yes, good. And how do you do that, Nico? You just have a second protection wire in order to deploy both of them?
Yes, you use 2 wires, and what I found very useful in a case that I had recently was a posteromedial, which is the most difficult to do, like yours, is I used one of the electrophysiology catheters, which are very big, and they bend a lot, so you can go from the interatrial septum and you can look down just over the hole, and then you can.
So you used the Agilis,
and right? Not the Agilis. There's a drive from catheters that are doing cryo or PFA, which are very big, and they're very bendy, and you can use 2 sheaths in this simultaneously, and you can deliver two plugs.
Also, the problem of this catheter, the flex catheter, is quite big, it's 12 French, but it's not supportive at all.
That's the reason that the electrophysiology catheter might give you a lot of support.
The Agilis is more supportive, but
yes.
It's 8 French.
You lose support when
yes.
you go medially. Yes,
right.
That's the problem.
This is interesting, yes. Good. So we have also three from the panel. They're Dr. Poulimenos, Dr. Spilias, and Dr. Triantafyllou. Do you have any comments? Can we have the three panelists, please?
Good afternoon. I could make a comment if
yes.
I may.
Yes.
Thank you for the invitation. Unfortunately, I could not be there with you. First of all, congratulations for having the courage to present such a difficult case that did not end well. I just have two questions. What were your considerations before the procedure, the first and the second, regarding the site of the transeptal puncture? And what were your plans regarding the best alignment possible to deploy the devices?
Regarding the first question, the transeptal puncture, when we aim posterior medial, so you have to, as we mentioned before, to have some high, so it's similar to mitral valve punctures. And regarding the alignment, you mean when you put the device, how you align the device?
Regarding the combination of the transeptal puncture and how you gain height in order to have the best possible ease and maneuverability in order to have a good alignment to deploy the devices, in order not to have friction when you deploy it. I mean, what was the position of the transeptal puncture that you aimed for?
Mid-posterior, actually, like when you want enough high in order to do all this curve and guide your steerable catheter to the posterior medium, where was the...
So it's not posterior inferior, it's posterior medial, let's say.
Posterior medial. Yeah.
Okay.
There are opinions that say that posterior inferior is the best one in order to have the height to be at ease with maneuvering in the atrium, but this is open for discussion. Anyway, the posterior leak that you had was very difficult to reach, and I think at the end of the first procedure, you had a residual leak. I was expecting you to say that you were going to implant a second device to completely seal the leak. Am I correct or not? Or did you just accept a good result in order not to make things too complicated?
Yeah, there was a mild residual leak after the first procedures, but as I told before, because the main problem of the patient was the heart failure and not hemolysis, we were satisfied with this result. It was a very fragile patient, so we stayed there.
Okay, good. So we have to leave it there. So thank you, Dr. Kalogeras. Dr. Voudris will present the next